Hello, everyone. Today we are going to focus on extragenital CT-NG testing at scale, and this will be the clinical performance of BD CT-GC TV2 on the BD COR system. I'm Melissa Davis, a medical science liaison at BD, and I'll be your moderator for today's event. Today we have Dr. Barbara Vanderpool, the inaugural holder of the Endowed Professor in Sexual Health Research at UAB Heersink School of Medicine, with a joint appointment in the UAB School of Public Health. She serves as the director of the UAB STD Diagnostics Laboratory. She has been active in the field of biology, epidemiology, and diagnostics of sexually transmitted infections for 40 years. Her behavioral research focuses on delivery, utilization, and implementation of new diagnostic technologies. So I'm going to pass this off without further ado. You can go ahead and begin.
Thanks, Alyssa. It's always pleasant to be here and to share things with a group of people that do what I do. There aren't that many of us, it seems, anymore that really are engaged at the laboratory end. So it's nice to share data with you. So I want to start by just setting the stage for what we're going to talk about today. And basically, I want to convince you, if you're not already offering extragenital testing services, that this is important to you in your lab. And this is something that you should really consider offering. And then we can talk about what's available. And I'll share with you some data that my group generated using the BD COR clinical system. And then we'll talk about the impact of high throughput systems as we go along. Okay, so why should you be doing testing for extragenital chlamydia and gonorrhea? I want to just start by saying when I talk about extragenital, I'm talking about anorectal infections and throat infections. The throat infections are predominantly in the oral pharynx. The rectal infections really do occur in rectal tissue, but we can test for them using anal swabs. And so that's why a lot of times you'll see anorectal as sort of a hybrid to describe where the infection is and where we collect samples from. So these are some data that are almost 20 years old now from the time they were actually collected. They were published in 2009 from a study here in Birmingham, Alabama, which is where I'm located, showing that at the STD clinic, among men who were willing to provide a rectal sample, which is predominantly men who were having sex with men, we got most of the infections for chlamydia from that rectal compartment with anal swabs. You can see that a minority of specimens were positive in the genital compartment. So for gonorrhea, that's not quite as true, but it's still pretty striking. So you're still having about 60 to 70% of infections that are isolated to the rectal compartment. And so testing the genital compartment is probably not as effective as we would wish. What's interesting to me is that this is not the case for women. We do see rectal positive samples from women. And when we used to do culture back in the 80s, we could see rectal positive cultures. So the infection can take root in the rectum and grow there. However, in most cases, this is the result of autoinoculation as opposed to sexual behaviors. Not in all cases, but in most. And so for women, genital testing actually identifies the majority of the infections because that's generally where they started. So the picture's a little bit different for gonorrhea in the oral pharynx. And for that, you see an almost even distribution of where those are isolated from. They could be in the oral pharynx or they could be in the genital compartment. So testing is a little bit less clear cut when you're thinking about gonorrhea, and especially if you're thinking about the oral pharynx. So based on those data, and at the time I was living in Indianapolis, and so I worked with our local health department there to replicate that. We did over 14,000 tests over the course of an entire year. And again, we saw very similar patterns. The pattern is that almost all of the chlamydial infections in men who have sex with men are isolated to the rectal compartment, whereas the gonococcal infections are spread a little bit more evenly. So you probably need extragenital and genital testing. In women, the same pattern. We see most of those infections could be detected using just a genital specimen. So in this case, a vaginal swab. This was important to us because it told us that using these sample types was a way that we could expand testing access. Data from a study that was done from 2018 to 2020. And these were samples that were collected from gay and bisexual men who had sex with men. And in that setting, in these populations, 75% of all the infections could be detected with just an anal swab. But you're still missing 25%. So do you want to still do genital? Yeah, probably. You need a urine specimen for these people. Do you want to do oral pharyngeal? Well, we only got one positive throat sample that was not positive at any other site. So we could go to 2-site testing, not quite as expensive, obviously, as 3-site testing, and we could detect almost all of the infections. We could detect 97.6%. So most of the infections could be detected with anal and genital sampling. Now, what was interesting is, again, that same pattern. In men who had sex with women, but attending the same clinics, we never saw anorectal or oropharyngeal positives. All of the positives were isolated to the genital compartment. So it's worth asking about sexual behaviors and sexual exposures. And it doesn't really matter how a person self-identifies as gay or straight or other, bisexual, whatever. What matters is, have they had an exposure event? And that's the question to be asking, because if they've not had an exposure event at the rectal site, they probably don't need to be tested there. You see that in women, again, about 3/4 of specimens or infections were identified just by genital testing. So probably it would be helpful in some populations, and particularly those women that say that they engage in receptive anal intercourse, to go ahead and do anal testing as well. The oral pharyngeal, again, if you try to restrict that based on behaviors and you ask people, are you engaging in oral sex? The answer is almost resoundingly yes. And so that's not a good, useful tool for trying to restrict testing to people who might have an infection. But the number of infections identified only from that site are really, really quite low. So it's probably not necessary to test the throat. But it's doable if you want to do it, because if it makes you an all-around provider that can service whatever your clients are asking for. So what should your clients be asking for? Well, here are the CDC recommendations, and this is just a summary article that was written by Brad Stoner and colleagues a couple of years ago. And in this study, they said that routine testing for gonococcal and chlamydial testing should be done at least annually, and that rectal and pharyngeal sampling is recommended depending on sexual practices. And they remind us that approximately 70% of infections are missed if we do urogenital only testing strategies. So that's just a summary article that was published, but in 2021, the actual CDC guidelines for control of chlamydia say that the use of molecular assays has changed our thought process, such that self-collected rectal samples are useful, and self-collected rectal samples are, and they really are anal samples, so forgive me when I say rectal, but this was the language that was in the guidelines. But self-collected samples work as well as clinician-collected samples. And then they recommend that annual screening be performed for chlamydia among men who have sex with men, and again, using self-collected rectal swabs. And they do recommend that extragenital testing at the rectal site be considered with women in the process of shared decision-making with a provider. So again, that's going to be a conversation that the provider is going to have about the woman's sexual behaviors. Now, for gonorrhea, they're similar, but they also remind us in the treatment guidelines that gonorrhea has different rates of positivity in different geographic locations, but also in different communities and populations. So when we say communities, we don't necessarily mean neighborhoods, right? We mean communities and populations. So men who have sex with men are at higher risk for gonococcal infection than men who have sex only with women. And these people should be screened every 3 to 6 months at the site of exposure. So again, you can probably do 2-site screening for most of these people. At least annual screening is recommended for all men who have sex with men. And I would remind you that for people who are on PrEP and people who are living with HIV who have an undetectable viral load, many people choose not to wear condoms any longer, and that puts them at higher risk of exposure to an STI like chlamydia and gonorrhea. And that's why this frequent screening is recommended. But for those of you who think about such things, remember that your pretest probability when you're testing somebody every 3 to 6 months is quite low. So your positive predictive value may also suffer from that. But the other thing that's important is that if you test people who are not on PrEP or not living with HIV, these people may have an infection that suggests that it should be useful to talk with those people about PrEP. So finding these infections is actually quite important for HIV prevention. And recent estimates suggest that STIs are still responsible for about 10% of new HIV infections in the US. So it's really important to do this screening whenever possible. And since many of us in the lab don't really know exactly where the samples come from that we receive if we have a large catchment area, it's worth remembering that in the United States, when surveys have been done about people's identification of themselves, people are really strongly identifying as being part of the LGBTQ plus community. Now, this does not mean that all their behaviors, this doesn't mean they're all men who have sex with men. This includes women, this includes trans people. But what you can see is that between 1 in 5 and 1 in 3 people living probably within your catchment area actually may be self-identifying as LGBTQ plus, and that means that they may have higher need for extragenital screening than people who do not identify as belonging to those communities. And another thing that's important thinking about that is that we've seen changes in time and based on age. And people that self-identify as belonging to this community are more likely to be younger. And what this means is that over time, more and more people are going to continue to identify with this population group and therefore potentially be in need of these services. So when you think about whatever your demand is today, that demand should just continue to grow over the next several years. And so sometimes I think it's important to make sure that we remember what the big picture is. It's not just that one swab and that one chlamydia or gonorrhea result, but this is what all that informs, right? So we can see that if we look at sexual behaviors for gonorrhea in particular, we see that among men who have sex with men, and this is self-reported, the number of infections is quite substantially higher than among men who have sex with women only, and then even higher yet than women. So again, if you're serving a population that serves men's health needs, the likelihood, if you're serving a population that includes gay and bisexual men, the likelihood that you should be doing extragenital testing is quite high. And really just basically what I'm saying here is that chlamydia and gonorrhea in particular remain highly prevalent. You may have seen information in the news that these rates are going down a little bit, and they have gone down a little bit, but we still have rates that are higher than almost any country in Western Europe and higher than in many places in the world. So we still have a substantial problem here, and that problem tends to localize in certain groups. And so we need to make sure we're offering them the services that they need. And rectal and throat infections, it's important to remind clients, and by clients, I do mean providers, but also patients. Because remember that people can be tested for HIV or for syphilis with just a blood draw. And that's because obviously those are systemic infections and they're testing for antibodies which circulate systemically. And you and I get that. But the patient and sometimes the provider doesn't always. So it's really important to remind them that just because they have a urine negative sample, that doesn't mean that there's not an infection somewhere else in the body. So we need to make sure that people understand that. And of course, as people begin to understand that, we need to make sure that they're offering testing services that support those needs. And as a laboratory, then we have to be able to offer those services to our clients. So hopefully I've convinced you that these infections are out there, they're highly prevalent, and that testing just urine specimens, particularly for men, or even only vaginal swabs for some women, isn't as effective as we could be, and we need different solutions. So that's why we're going to talk about the BD COR, because the BD COR was submitted and reviewed by the FDA and does have claims for extragenital samples. So I want to share that study design with you and then the data that we got from it. So in this study, we ran 4 assays. We used 3 of the 4 to determine the infection status. So for example, if we were trying to estimate the sensitivity for assay, let's say D, we would look at assays A, B, and C, and if 2 or 3 of those were positive, the person was classified as infected for this analysis, and assay D was compared to that infection status. So basically, we took the 3 swabs per patient, we put them into one tube. Now, in this study, we used liquid-based cytology media because every assay we were working with had a claim for liquid-based cytology media. So we could run it on each platform. And so then whatever your test is that you're using to evaluate, you compare it to the results from the other 3 tests. So these results are what we called the composite comparator algorithm. If 2 of 3 of these were positive, that sample was considered positive, and if 2 of 3 were negative, it was considered negative. And this is all published and in the article that comes from 2022 in the journal Sexually Transmitted Diseases, if you want to see it. But we had remnant specimens, and we stored those at minus 20 degrees, and so then these remnant samples were used for this BD COR analysis. So they did the BD COR testing, and they compared it to the CCA. So we didn't do extra testing, we just compared it to the original study's results. So what we could see from the BD COR, we had almost 2,300 anal samples, and 129 were defined as infected based on this complicated algorithm. And for chlamydia, the BD COR had 97.7% sensitivity, and it had 99.4% specificity, so that's quite good. For the oral pharyngeal specimens, 100% sensitivity and 99.8% specificity. So you can see that the specificity is quite high here, which is something that we really care about. And here we have the results for gonorrhea. Again, good performance for sensitivity. From those 292 anal samples, the BD COR correctly identified 96% of the gonococcal infections, and they identified 93% of the oral pharyngeal infections. And again, the specificity here is quite high at 99.5%. So again, you can have a little bit more confidence that when you are doing this testing, even if you're testing in those populations where you have a low pretest positivity prediction, you still can have pretty good confidence in your results. But you still do need to be aware that you may need to do some sort of alternative testing to confirm those if the provider asks you for confirmation for any reason. And then I just want to wrap up a little bit by talking about automation and why I think that some of these platforms that have really high throughput now offer us advantages that we're really interested in. And I think the key, of course, for most of us who work in the laboratory, it's all about money these days, right? And everybody at the higher end above us is just trying to control our costs. And that is because of reimbursement rates. It's because of just a whole slew of things. But lab efficiencies are critical to our functioning. So walk-away time is critical to begin with because that allows your staff to do multiple things. I can have one person run multiple instruments in a day, of course, because once they load these and they have 5 hours of walk-away time, they can do whatever they need to be doing. And high throughput systems also really minimize reagent waste and tip waste, consumables waste, right? Because if you think about it, when you put on something that's designed to run in 48s or 96s or whatever, and you run small batches instead, you're going to waste a lot of those reagents. But the other thing is assay controls. If you have to run assay controls daily, the more samples you can get out per control set, the lower that number of controls per results is, and so the lower your charges can be. And I know that it seems sometimes like controls are a minor thing, but if you look at what you're paying for them, they're probably not minor. And if you have to run a lot of those, like if you have to run controls with every 24 or every 48, as opposed to every 600, it's a huge difference. And so that does add up. And it doesn't sound like it, but it really does. The other thing is that with these automated systems, there's two things that are really important. And the first is when you've got integrated sample prep and amplification detection, that means that you don't have to have separate workspaces. There are a lot of people out there that are still using systems. Some have LDTs because they found it easier to validate the extragenital samples on an LDT than on the platform they were using. So people still have LDTs, and they have LDTs that have a DNA extraction process and then an amplification and detection process. But if you really have different instruments doing that and their samples moving between those, you have to worry about carryover contamination. So it's very helpful to have something that's a sample to answer result process. So that's one of the reasons automation really helps us. The other thing is some of these assays with these high throughput no longer need highly trained molecular microbiologists. And so for some of the assays, they're still classified as CLIA complex. And that means they have to have a great deal more oversight, and the person running them has to have very specific training. However, for things like the core that are classified as CLIA moderate, now you can have more people within your staff running that piece of equipment. And so it really, again, helps you really maximize your staffing efficiencies. But before you take on a new system, if this is something that you're in the market for, there are things that you really should think about. I would strongly encourage you, based on the evidence that I've shown you today, to consider a platform that has claims for extragenital sample types. If you do that, that means your onboarding is limited to verification studies and you don't have to do large-scale validation studies. And again, you consider the throughput as an efficiency factor, but also consider the menu depth as a way to offer more comprehensive services. And one of the things that I like about the BD COR is it can run a lot of different tests and assays. So it can include chlamydia gonorrhea, which is what you want for extragenital samples. It can include trichomonas, which is what you want if you test women. But it can also include causes of vaginitis. If you're serving clinics or populations like urgent care, where women tend to come in with symptoms, you probably need causes of vaginitis as well. And it can also run HPV screening and typing, so it can provide your cervical cancer screening opportunities as well. And this allows you to have one instrument that, for all of the things shown, the chlamydia gonorrhea, the trichomonas, and the vaginitis, you can run all of those from the same sample. All right, before I start coughing, I'm going to sum all of this up. My take-home messages are pretty simple. Your lab probably needs to support extragenital testing if you're not already. If you're thinking about adopting a new test, or if you're thinking about self-collection claims, there are a couple of helpful review articles here. The one by Crumpler and colleagues is really designed to help people understand the data that are going into the CDC's recommendations and guidelines for laboratory testing that, knock on wood, will be published soon. But that's why we went ahead and published the background data that CDC used to make their guidelines, because we had the ability to get those published and out the door. So I would really, really recommend that you look at that article. But I do think that no matter how good the data are, and when we look at the sensitivity and specificity, the people who are the decision makers about what systems you adopt are really making those decisions based on lab efficiencies and cost considerations. So it's really important that you understand how these different systems can interact to offer you the services that you want to offer to all of the clients that you have. Alyssa?
Thank you so much. I love the kind of wrap up of the offerings for core, because as a clinician myself, and I think on the lab side, we love a one-stop shop, kind of an option that can do it all. And I think this is really highlighting the way that things are moving within the diagnostic space. So thank you so much for your presentation. And I also love discussions like this that focus on the lesser kind of focused areas within sexual health, and really trying to ensure that labs have a comprehensive sexual health offering for their patients and providers. I do just have kind of a wrap up for you. We really appreciate your time, and I would love to have kind of a quick takeaway. If the lab audience has one message to kind of take home with them and use throughout their practice, what would you have to say to them?
Consider talking to people about sites of exposure, as opposed to categorizing people as being in this group or that group. And that would help you get at the women that need to be tested, and helping clinicians understand how to offer those conversations is not really the lab's job. But on the other hand, I think maybe we're in a position that we maybe have information they don't have, and we really need to share it. So trying to encourage our clients to do the kind of testing that we think would help their clients is where we are right now.
Great. Well, Dr. Vanderpool, thank you so much again for your time today and your ongoing, very important research. Thank you so much, everybody.